We're presenting on a contraception case study. So Brandy Miller is our case client. She's an 18-year-old African-American woman. She comes into the clinic to talk about birth control, and she's interested in 3 different options: oral contraceptives, Depo-Provera, or an IUD. In assessing her background, we want to look at a kind of a multitude of factors. So in the psychosocial sphere, we want to assess her feelings and fears about contraceptives and sexuality, her sexual history, any history of sexual trauma, drug or alcohol use. We'd want to look at her physiology, any history of STIs, yeast infections, UTIs, pelvic TB, in part just to see how her anatomy was, and it might be affected by some of those infections, and also for drug-drug interactions. You want to look for previous pregnancies and breastfeeding history, a distorted uterine cavity, or any unexplained vaginal bleeding. As far as developmental part of her background, you could assess Erickson's stages. So she's kind of on the cusp of finishing the identity versus role confusion stage and entering the intimacy versus isolation stage. So she's kind of, if she's on track, she's worked through kind of creating a stable identity and moving into the ability to kind of develop the virtue of love. You'd also want to check and see any puberty and developmental milestones and assess her educational level. As far as environmental background, you'd want to kind of figure out some stuff about her schedule. Is it regular? The same thing with her housing. Does she have a stable housing situation? Does she move around a lot? Does she have good access to health insurance and access to transportation? Is that going to affect her ability to make it to visits and receive the healthcare she needs?
Okay, so before a patient starts birth control, there are several important areas that need to be assessed. As with all medications, any potential contraindications should first be determined so that a patient isn't placed on a medication that either won't work for them or will be harmful to them. And contraindications vary by medication and need to be examined thoroughly. There are many examples of contraindications to the contraceptive methods we'll discuss here, but to give an example of some of the contraindications for the pill, it should not be taken for women who have had blood clots or a stroke, have liver disease, have abnormal or unexplained menstrual bleeding, or who are smokers older than age 35. You'd also want to find out the date of the patient's last menstrual period, since this may affect the start date for the method of contraception. And you'd also want to ask about any past contraception they've used to see if they had any adverse outcomes, because if you're starting them on another medication with a similar mechanism of action, you'd want to monitor them closely for this reaction to occur again, or prescribe another contraceptive method. You may also want to perform a pregnancy test to determine that she isn't already pregnant when you're starting her on contraception. And you'd want to assess sexual activity. An example of when this would be important is for a woman who thinks that birth control pills are sufficient for her, but she has multiple sexual partners and really needs to be using condoms or some other method to protect against STDs. You should also evaluate the woman's blood pressure and continue monitoring it as long as she remains on birth control, since certain contraceptive methods can cause blood pressure fluctuations. And while pap smears are recommended for overall reproductive health, they are not actually required for the initiation of birth control, but a pelvic exam may be required before placing an IUD. And actually, there are no specific diagnostic tests that are mandatory before starting birth control.
So when it comes to teaching Brandy, we want to assess her and make sure we're giving her the information in the best way for her. So we would ask her about her preferred learning style. Is she visual, verbal, oral, or physical learner? And present information according to that preference. We're going to present information in various ways, such as videos, pamphlets, models, to make this material accessible and memorable for her. We're also going to individualize our teaching to Randy's desired outcomes and account for her personal beliefs, her strengths, and any health literacy levels that she has. And we're also going to discuss each birth control, the pros, the cons, and any potential side effects that she may experience, and then end and ask if she has any questions. Our first method is oral contraceptive pills, or the pill. It's available as a combination of estrogen, progestin, or progestin only. Typically, it has 3 weeks of hormonal pills and then 1 week of a placebo. It will stop ovulation, which will prevent fertilization from occurring, and it will also thicken her cervical mucus, and 9 in 100 women experience pregnancy while on the pill. Pros of the pill is a predictable period that's lighter, may have less cramping and PMS. If she has any acne, it may clear that up as well. And it may prevent against certain cancers like endometrial and ovarian, iron deficiency anemia, and ovarian cysts and PID. Some cons she may experience would be spotting in between periods. She does have to take the pill at the same time every day. She may have sore breasts, a change in sex drive, and this does not protect against STIs. Contraindications of the pill would be having a history of blood clots or breast cancer, liver disease, and being a smoker over 35 years old.
Our second form of contraception is the Depo-Provera shot, which contains the hormone progestin, which prevents the ovaries from releasing eggs, and it also thickens cervical mucus, which helps prevent sperm from getting to the egg in the first place. And 6 in 100 women experience pregnancy while on the shot. Pros are that it lasts 3 months, it might give you shorter, lighter periods or none at all. It can be used by women who can't take estrogen, and it's also safe to use while breastfeeding. Some cons are that the woman may have irregular bleeding for the first 6 to 12 months. She can experience weight gain, a change in sex drive, depression, and since the shot lasts for 3 months, there's no way to stop the side effects. And it also does not protect against STIs. Contraindications are current or past history of thromboembolic disorders, breast cancer, hypersensitivity to Depo-Provera or any of its ingredients, and liver disease. Next, we have the IUD Paragard, which is a small T-shaped plastic device with copper that is placed into the uterus. The copper interferes with sperm movement, egg fertilization, and possibly prevents implantation. And it's hormone-free, so you keep your menstrual period, and less than 1 out of 100 women experience pregnancy with the IUD. Some pros are that it lasts up to 10 years, it's safe to use while breastfeeding, and you can try to start getting pregnant the same day that the IUD is removed. Cons are that women may experience spotting between periods, an increased period flow, cramps and backaches. The IUD can fall out or perforate the uterus. Less than 1% get pelvic inflammatory disease, and it also does not protect against STIs. And contraindications to the Paragard are a distorted uterine anatomy, ongoing pelvic infection, allergy to any component of Paragard, and uterine or cervical cancer.
Our next method is another form of the IUD, Mirena, Skyla, Loletta, or Kylena. It's a plastic T-shaped device that is placed into the uterus, and it has progestin, which thickens your cervical mucus, and less than 1 out of 100 women experience pregnancy with an IUD. Some of the pros about these IUDs is that it can make your periods lighter to the point where you may no longer have a period, and it can also reduce cramps. It can be used by women who can't take estrogen. It stays in place for years, about 3 to 6 years, and it's worry-free. It's easy to remove, and you can get pregnant almost immediately after removal, and you can use during breastfeeding. Some of the cons is that it can result in spotting. You may have cramps or backaches. You could have infection after insertion. Especially within the first year, your IUD is at risk for falling out or perforating your uterus, and it also does not protect against STIs. Some of the contraindications for this IUD would be a distorted uterine anatomy, ongoing pelvic infection, or uterine or cervical cancer.
So now we would just want to take a look at our teaching and evaluate if it was effective for our patient. So we want to take into consideration, did we educate the patient based on her specific learning style preferences? So again, as it was mentioned earlier, some people respond better to visual learning, verbal, auditory, or physical. So different types of methods, including videos, infographics, models, might be beneficial for your patient. You just have to find out what works best. We want to see if we presented the information in a way that's individualized to the patient. So did we take into consideration the desired outcomes, her beliefs, her strengths, and her health literacy level? And also, did we allow enough time to teach her and for her to process and synthesize the information? So this would likely be done in a safe, quiet, neutral environment just between the provider and the patient, or the nurse and the patient. Later we can assess for further concerns or questions that the patient might have. We can assess if the client is making an informed decision about what contraceptive method is most appropriate for her, and we can kind of test and see if she really grasped the ideas that we gave to her during the teaching. So to do that, we can have her restate the educational material in her own words, and the goal here is to really have the patient clarify her rationale for her choice, so why she chose one method as opposed to another. You want to ask questions to assess the client's knowledge. For example, if the patient suggests that she is very opposed to hormonal methods of contraception, but then she decides that she wants to go with the Mirena IUD, there might be some sort of misunderstanding there, and further clarification may be needed. In special circumstances, we might need to take in additional learning needs into consideration, for example, an interpreter or written materials in the patient's native language. And also, if applicable, we could do a post-test.